So useful tips: severe thrombocytopenia in third trimester, LDH, peripheral smear, systemic symptoms, and renal parameters. Hypertensive disorders with severe thrombocytopenia, management, steroids, delivery. I will take another 2 minutes. So TMA during pregnancy, pregnancy specific, the optimal medical management and termination of pregnancy, whereas the general TMA is, disease specific. So collaboration with obstetrician and hematologist is essential for successful outcome of these life-threatening sequences. Switching gears further, the bleeding disorders, almost 5% of PPH belong to bleeding disorders. This can be coagulation defects suspected in patients who have persistent PPH or patients who have history of various easy bruisability and menorrhagia in the past. And so the workup is PT-APT mixing studies, and there is full correction factor deficiency, no correction inhibitor, again a serious alarm. So again the management is underlying coagulation factor replacement and then termination of pregnancy. Fast fact: no role of FFP transfusion in patients with any bleeding if PT-APTT is normal, right? So I see a lot of desperate use of FFPs and cryoprecipitators. Unless an underlying cause is treated, DIC won't resolve, and platelet rise is better with SDP. So last, sickle cell disease common in our region. So you remember first trimester hydroxyurea cannot be given, but severe patients who have been on hydroxyurea before, you can start at the second trimester. Mild disease, no previous vaso-occlusive crisis, you can start hydroxyurea in the third trimester. And patients who are transfusion dependent, continue chronic transfusion to keep target hemoglobin more than 9. Again, hematological malignancies. With a fantastic OBGY team at Yashoda group of hospitals, we have managed 14 patients who were diagnosed with deadly leukemias during pregnancy. And this is kind of, first trimester, termination of pregnancy, second and third trimester, medical management, and then getting the cancer under control, and then the delivery. So this has led to such. This is an air hostess we treated about 7 years back. She was diagnosed with one of the deadliest blood cancer, acute promyelocytic leukemia, during 34 weeks of pregnancy. We got her deadly APML into remission, and then her pregnancy, she underwent LSCS, and you can see 7 years post therapy, both the mother and child are fantastic. So blood disorders, blood cancers no more occurs even in the pregnancy, and each pregnant patient is different. So red flags for hematology evaluation: thrombocytopenia of platelet less than 1 lakh in first, second trimester, thrombocytopenia, hematological abnormalities with neurological signs, hemolysis with schistocytes on peripheral smear, sudden hemoglobin drop or platelets postpartum, refractory thrombocytopenia despite steroids, IVIG, and rising creatinine with these hematological abnormalities. Again, hematology is as I mentioned, a very wonderful specialty where algorithms work in 100% cases. So algorithmic approach can really save lives, and I'm sure from these cases you will agree with me that eyes are useless when the mind is blind, unless and until I had opened a Pandora of differentials where benign hematological issues can be effectively managed by you. But mind you, there are critical hematological abnormalities which needs collaboration with hematologists. So when to involve hematologist: any cytopenia existing more than 1 week, thrombocytopenia less than, platelet less than 50,000 at any gestational age. As I mentioned, thrombotic microangiopathy, clinical suspicion, postpartum thrombocytopenia with systemic signs, recurrent pregnancy losses with aplastic suspicion, and suspected blood disorders like aplastic anemia and leukemia syndrome. So all these blood disorders, this is a picture which is portrayed to us during our all these years of practice: ugly, cruel, hopeless, which is not true. With effective collaborative teamwork, 100% success can be achieved. So we definitely need to change our approach to offer the best possible chance of success and successful outcome in these high-risk obstetrics, and we can do it together. So quick pearls for obstetricians: gestational thrombocytopenia is common, benign, usually platelet more than 70,000. ITP response most of the times more than 95%. Steroids, IVIG, even TPO analogs like romiplastim, L-thrombo can safely given at third trimester. TTP requires urgent plasma exchange, delay can be fetal. HELLP syndrome may overlap with other pregnancy, hypertensive disorders or TMAs. Don't hesitate to question. Atypical HUS often strikes postpartum, and that is the time when you think everything is successfully concluded and may need targeted biologists. And look at the trend, not just one lab value. So with that, the future of medicine, particularly the obstetric hematology, is bright with a collaborative team with a lot of light at these suffering females and ladies. So take home message: at low platelets, all low platelets are not ITP. Think beyond ITP if the clinical picture suggests. TMA syndromes are rare but deadly. Early recognition saves lives. Peripheral smear, your best friend in emergency hematology. Don't ignore neurological or any systemic signs. They are red flags. Timely hematology consultation can change outcomes dramatically, and collaborative care between obstetrician and hematologist is not optional. It is life-saving. So again, just 30 seconds for a case which madam highlighted, 32-year primary. We managed this case at Yashoda, Somajuguda. LSCS outside for arrest of descent. Intra placenta was adherent, removed manually, after which she developed atonic uterus. Despite continued sequential uterotonics, oxytocin, ergometrin, carbopras, uterine compression sutures were given, shifted to us. At our place, we did bilateral uterine ovarian vessel ligation. Again, mind you, hematologist is not involved till now. Till now, the blood loss is 2 liters. Replaced with massive transfusion protocol and fluids. Post-op continued to have profuse bleeding, and young lady, remember 32 years, single child. They took her for subtotal hysterectomy, continued to bleed profusely, and this is when we were called in. Simple injection Novo 7, 60 mics per kg, 1 dose, almost complete stoppage of blood. Of course, 99% patients 1 dose is enough. Hardly 1-2% patients second dose is required. 30 minutes apart, we repeated another dose, bleeding stopped, and she was sent home on day 3. So this kind of coagulation factors now not just globally approved in India by CDSCO for the label of treatment of severe PPH when uterotonics are insufficient to achieve hemostasis. And this kind of knowledge updates, unless and until we team up, we won't. So we are masters of our individual specialties. Beyond our individual specialties, we are lay persons. Unless and until we collaborate, these kind of successes are not possible. So again, behind every CBC lies a chance to save a life. Let's not miss the window. And hematology isn't the final referral. Often it's a life-saving detour for all these high-risk obstetrics. Thank you so much for your kind attention. And I'll be happy to address any questions.